Hello and welcome to Quarter 2, Structure. So this is your basic neuroanatomy course and I'm Dr. Julie Kotiw. The letters here after my name mean that I have my diplomate in chiropractic neurology. I did that through CNI, through Dr. Dishman here at Palmer, Florida, and I also have my doctorate of chiropractic. I did that here at Palmer, Florida as well. I'm a 2009 alum. I have my bachelor's degree in general science. I was also a certified massage therapist before I became a chiropractor. So I worked in chiropractors' offices for a couple of years and saw the amazing things that chiropractic can do and decided that that's what I wanted to do with my life. I also went on a retreat and became a certified yoga teacher as well, which really helps a lot with the physical active care that helps with the work that we do. So that's me in a nutshell. I've taken what else here? So I was the bioscience department chair at my previous position at Pacific College of Oriental Medicine up in Chicago in the Loop for about 4 or 5 years. There I taught every class there is in the science department, basically. So I taught anatomy and physiology of every organ system. I taught pathophysiology 1 and 2, also in the doctorate program. I also taught, orthopedic and neurological exam 1 and 2 in the doctorate program. And I also taught in the massage program as well, and that was super fun. So I taught science and massage techniques and kinesiology. So I'm well versed in many different ways of natural healing. I've also been doing acupuncture for the past 10 years. What else? I had my private practice, so the practice I started directly out of school, same within a week of graduating from Palmer. I was in practice for myself. I sold that practice after about 5 years. I grew it from working by myself, not even being able to afford an adjusting table, just my old massage table, massaging patients and adjusting them using an anterior board and SOT blocks. And then I ended up being able to hire another massage therapist, get a real adjusting table, hiring another chiropractor, a couple more massage therapists as well, an acupuncturist, a medical doctor that was doing trigger point therapy for anesthesia, for pain, basically in the upper traps and piriformis. And I had 2 offices at one point, and then I decided to retire in 2014 from that so I could travel and teach. So I could answer any questions that you have on how to start a practice on a shoestring budget in a recession. So mind you, I graduated in 2009. So, but what we do here is I teach you neuroanatomy. So I'll be your neuroanatomy professor for quarter 2 and for quarter 3 for advanced neuro. So we need 2 quarters for this because we're chiropractors and we know that the nervous system controls and coordinates every single aspect of the body, and it's a pretty complex system. So we take our time, and first in basic neuroanatomy we're going to just get the basics down. We're going to learn the language, we're going to learn the basic structures and their basic functions, and then in quarter 3 it goes a whole lot deeper and we get a lot more into how to use this in functional neurological rehab. How do we study the structures, understand the function, and then what do we do as chiropractors with this information? So that's my goal for this course, and hopefully I'll be able to see you in person soon. But until then, let's go ahead and get started. So we're going to go through your syllabus. We're going to talk about what books that you'll need. We'll talk about your Brightspace page. We have weekly interactive lab lists. So lab will be a little bit tricky until we can actually get in there, but the idea is to prepare you well so you know what structures you're looking at ahead of time. So when we actually get in there, we've maximized our time and you'll know what we're talking about. So that's the goal for that. You'll have your ALS, your active learning sessions with Dr. Norkus, and he will reach out to you about information with that. He'll be in the virtual classroom during your actual section times for that. Weekly quizzes is how we're going to keep track of things here. So your weekly quizzes, you may have heard from previous students that these were extra credit. These are not extra credit now because this is our format here for online. So you should be able to use your resources and do well on those. And that's how we'll be checking in that you are keeping up with the work. So that situation might change after those are already counted, so maybe if we get back into our regular swing of things, maybe there will be extra credit available to you, but not right now because frankly, we really don't probably need it because you'll be able to take your time and look things up. So weekly quizzes on Brightspace, so they go chapter by chapter. The book, so up there on the PowerPoint you can see Nolte's Human Brain, that purple book there. So that's the required book. That's what we go chapter by chapter. So that's available to you online, and also you can order that from maybe Amazon. I'm really not quite sure. We can look up resources for you. Most people just use the online version of the book. So you'll need this for quarter 2 and for quarter 3, so it is a good investment. There's also practice quizzes through the Nolte website as well, and I take some of my test questions from there. And the reason I chose this book, Nolte's Human Brain book, is because NBCE uses this book in order to create your boards from. Okay, so it's a resource that they use to create their test questions from. So we want to prepare you very well for that, so you do well with that. So that'll be spinal anatomy, and then some of your function as well, and some of the differential diagnoses as well in there. So let's look here. So recommended, the other one up there, so that's the Manter and Gatz book. So clinical neuroanatomy and neurophysiology. Usually we call that Manter and Gatz in the neuro world. So when we're studying neurology or referencing, saying, hey, this resource says this, this one says that, usually what we'll do is we'll say, hey, well, what does Manter and Gatz say? And then we check this book, and that's the go-to. So Manter and Gatz, it's a cheap book. You can pick it up for about 13 bucks on Amazon as paperback. You can sit by the beach or the pool or wherever you are social distancing at, and not be afraid of getting it damaged from water damage, beach damage. I know mine is well loved at the beach. That theme book, that's a big book. That's a great book for lab. That's a great book for the idea that you guys probably aren't going to be in lab. Nolte's also has a couple chapters that work well for lab as well. But I use that theme book a lot when you see the pictures that need to be kind of filled in. So you'll understand what I mean. I have structures with lines, and they're labeled, and then I have them blanked out, and a lot of that info comes from that theme book. So let's move on to the next slide here. So these are the pictures of the different editions of the book. So there's really, honestly, not that much of a difference between 7th, 6th, and 5th edition except for price. So the 7th edition is what's available online though, and through their interactive website. So the structure of the class here. So what do we want to do? So we want you to ace this course, right? So we want you to do really well in basic neuroanatomy and advanced neuroanatomy. We want you to be able to ace your boards as well. We don't want you worrying about that board test. We want you to walk in there feeling safe and secure and well-trained and ready for that board exam and to do well. Most importantly, what I want you to become amazing healers, and understanding the nervous system and how it works is vital to becoming a healer. So as chiropractors, we have a saying, right? The central nervous system controls and coordinates every single aspect of the body. It's above, down, inside out. Take that for however you like to take that. In the neuro world, we think about it as the brain, right? Brain above, down, spinal cord, inside, and then out. So that's a common saying that we have. And the nervous system is an extremely important system to fully understand as chiropractors. All right, so ace the class. So normally this is set up for in-person classes, so I would expect you to come to class. It's hard to ace the class if you're not here. but you'll be here because you'll be able to play these recordings whenever you want. So even if you have a neurology background, there's always another level of understanding to achieve. So even with all of the work that I've done, all of the classes I've gone to, all of the classes I teach, every once in a while I'll say something and understand it in a different way. I'll have said the exact same piece of information 20 times over for the class, but all of a sudden it'll click in a different way, and I'll put it together and add it to my functional neurological rehab program and start making a difference for people that need that type of care. So always keep working on it. It's never, ever, ever going to be something that's like, oh, done, we're done studying the nervous system. We totally understand it. It changes every day. We have resources on Brightspace, so check that out. There's a handout section. There's videos posted. Check out those quizzes like I talked about. There is tutoring available, even online. So we have tutors set up for you. So I will put their resources on Brightspace for you, and you can reach out to them. So look for an announcement with their information. Ask me. Email me. You don't know me yet, but I'm very approachable. Ask my previous students. Ask me anything, email me. I will be happy to help you. I also have a cell phone number posted for you as well. Feel free to use that. Text me anytime. I only have that on me during work hours, so you won't be disturbing me on my time off. And that's not my normal cell phone, so it's not something I check and keep on me all of the time, only during working hours, like you would expect my office phone to be. So I'm accessible to you through that at any time. Open anatomy times, there will be open anatomy lab once we get everything back up and running in person. In the meantime, I will have videos posted and resources available for you for that. So if you're struggling, ask for help. We've all been there. It's not the easiest subject that there is, but it's well worth the effort, because once we figure this out and master this, if you can even say that we've figured it out or mastered it, but the more we know, the more we can help people on a different level. So neuro rehab. So one of the things we want to do is focus on the positive. So we don't want to focus on the negative. So as students, this is important. Don't focus on the negative things, on the hard parts of things. Focus on the fact that you're going to be helping people. Keep your goals in mind of why you showed up here at Palmer in the first place. Why do you want to be a healer? Why do you want to be a doctor of chiropractic? Focus on the positive, the long-term goal, and that'll help you get through some of the short-term goals and the hard parts. But one of the things that we do in neuro rehab is we have to praise people, praise each other, say what's good about what we're doing and the progress that we have. So that changes our mindset, and it's all about mindset when we're talking about the nervous system. So it's that above, down, inside out. So if we have the ability to be positive and give that positivity to our patients, they're going to use that. You could call it the placebo effect, that's fine. Placebo works. So they're able to use that mindset and program in a de-stressing program of healing and an understanding that, hey, somebody's got this information for me and I can get the help that I need. That's your patient wants to know that you know what's going on and that you have a positive prognosis for them, or at least a positive attitude for them. It works the same when you're trying to understand your studies. So focus on the positive, keep a good mental outlook, ask for help when you need it. We've all been there. We've all had those little mini mental breakdowns, those rough days, the feeling of failure, impending doom, but we get through it. And we get through it by showing up and showing up for each other and rooting each other on. So the brain is going to understand neuro rehab a whole lot better if we're positive about it. So this slide is telling us how to train a dog. If you've ever trained a dog, positivity is the way to go. So this happy guy here, who knows what he did, right? But you throw what we call a dog party. So throw your dog a party every time, but it's a dog party. They're always ready to party down, and they're going to get trained very quickly that way through positive reward instead of negative. So use that on yourself, use that with your patients. Celebrate the little victories and they add up. So if we were in person here, I would ask you guys, what do you want to do, right, with your life? Why are you here? Why did you choose this profession? And most of you, with any luck, would say to help people, right? And then I would ask you, help them do what, right? So what do you want to help them with? So what are they coming in there for? So most people show up at a chiropractor's office. Number one reason is to address pain. So that's how they walk in the door, and then we have to address their pain, and then we get to show them everything else that we do. So the wellness aspect of it. So how are you going to use the information here and what else you get from your other classes in order to help your patients? That's one of the thought processes I want you to have in the back of your mind while we're going through this program. Set an intention. It's extremely important. We use it in our notes in chiropractic. We have to have a goal, and then we make strives towards that goal, and we achieve steps towards that goal. Insurance requires that we have that in our chart. What's the short-term goal? What's the long-term goal? What's the plan on getting there? Insurance requires it, honestly, because it works, and it's a way to see, hey, how are we doing? So set goals for yourself, short-term goals along the way, and then accomplish those goals, or figure out why you haven't accomplished those and ask for help if you need it on how to accomplish that. Okay, so we use that on ourselves. We use that with our patients as well, because it's good science in healing and learning. One of the things we want to talk about is help them create a goal that isn't just an absence of pain. So that's a really good goal for a short-term goal, to get out of pain, right? A 50% reduction in pain in 2 weeks, 100% or 90% or above reduction of pain in a month, depending on what they're dealing with. And then let them see the light of what else chiropractic can do. So have them set a new goal. What are you going to do with your new pain-free body? What's your goal? How do you get happy if they're not already happy? Most of the time, if they're in pain, they're probably not so happy. So what changes do we need to make in order to create a situation in which you don't go back into that painful situation? Or what do you now do with that gift of a pain-free body? So that's the idea. Show them what else is out there. So have them go after that as part of their wellness goal. Great. Let's move on to the next slide here. So this idea here in this pep talk on what we're learning is performance improvements from imagery. So this is a paper here. It's published on PubMed. It's from, where is it from? Frontier Human Neuroscience from 2013. So the title here, Performance Improvements from Imagery, Evidence that Internal Visual Imagery is Superior to External Visual Imagery for Slalom Performance. Now, you can use anything instead of slalom performance, but they do this with Olympic athletes. So they have to visualize themselves succeeding. Visualize yourself happy. Visualize yourself succeeding, visualize yourself understanding what you want to know, visualize yourself happy in practice and successful, whatever that means to you. And then impart that wisdom to your patients. Have them visualize themselves being pain-free, visualize themselves being healthy, visualize themselves being happy, and what does that look like, and build from there and help them achieve that goal. We know that it works, and it's proven and it's published. So functional chiropractic neuro rehab, I think about this quote: medicine is the study of disease and what causes man to die. Chiropractic is the study of health and what causes man to live. So this is B.J. Palmer, so one of our founders here, and I think these are true words still today. So we want to talk about what creates vibrance in our patients' lives. So not only just getting them pain-free, disease-free out the door, but what's going to get them out into the world and serving the greater good? What is going to make them happy? What is going to make them productive, happy, healthy people out in the world doing good? Questions to keep in mind during your studies of the nervous system and in treating patients in general, ideas that you can ask questions to them about. So one of the questions that I like to ask is, what would you do if all of your needs and everyone else's needs were met? Okay, so most people, if you ask them, what would you do if your needs were met, they'd be like, well, I'm going to help others then. Okay, great. That's exactly who we want on board, right? But what happens then if they didn't need help either? What does that homeostasis look like on a broader level, right? So we think about it in the body, but what does it look like on a deeper level, on a macrocosm instead of the microcosm of the body? We're going to look at these different dichotomies: rest and digest, fight or flight, different levels to try and create this homeostasis. So we don't want these big, huge swings between things. We are trying to achieve this homeostasis mostly through negative feedback systems of the body. Something happens in the body and we're like, oh, nope, need to put that down. Or something's going on in the body and we say, oh, we need more thyroid hormone, or we need more of, we need to maintain that blood pressure and bring that down. We need the blood sugar down. We need different things to be maintained. What happens when we actually achieve that balance? Now what? That's the question that I like to pose to my patients. Now what happens when you achieve balance? What happens when we get you your stress reduced enough to where you don't really think about it that much on a daily basis, that it's not dictating your life anymore, that that pain is reduced. So again, we're going to look at these different dichotomies in the nervous system and try and relate them to everyday life for ourselves as healers and for our patients as well. So it's the basic concept of what is this axis that we're spinning around? Okay, so we're hanging out at this homeostatic line, which we don't really get to that flat line. That's not life. But we're up and we're down. What is that line? What does that look like? And what would happen if we actually achieved it? So this dichotomy that I'm talking about is this balance between things. So we're going to talk about sympathetics versus parasympathetics. So we're sympathetic dominant in this society usually. So this fight or flight, go, 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 go. There's no time for rest. Rest isn't adequate. And then it leaves us with all sorts of diseases of the sympathetics being in overdrive, things like high blood pressure, high blood sugar, anxiety, depression, things like that. And then parasympathetics. So some of us try and push into that parasympathetic state or that rest and digest by eating too much, and then going into kind of a depressive state when we actually do get to sleep, maybe sleeping too much and not finding that nice balance. Sometimes people can't eat at all when they're stressed. So a balance between sympathetic and parasympathetic, what does that look like? What is that sweet spot? Where does that happiness lie in that system? Between disease and health as well. So what does it mean to be healthy? That's one of the questions we want to answer. I don't think it really has a very good answer. It's this kind of vibrance that we're all trying to achieve, not just absence of disease, but an actual thriving in our life. What does that mean? What does that look like? One of the dichotomies I like to talk about in neuro is Parkinson's and schizophrenia. So Parkinsonism versus schizophrenia. So we know that Parkinsonism is one of the salient features is that it's not enough dopamine. Schizophrenia, excessive amounts of dopamine. What's the right amount of dopamine? So that's that kind of happy, normal, happy medium there. What does dopamine do for us? It's that reward hormone or that reward chemical. So the drive that we have, some people, it's that drug-seeking behavior is driven by dopamine. Dopamine is that hit that we're looking for of reward. So the idea that Parkinson's is not enough and schizophrenia is too much, and there's different disease processes for excessive and deficient as well. So think of things like high blood pressure or low blood pressure. How about high blood sugar and low blood sugar? Different things like that in our disease state. Anxiety, and then it's exhausted relative depression, right? Manic. Okay, so manic and depressive, that bipolar concept. Right brain and left brain. So what's going on with that? At the end, we'll watch a video by Jill Bolte Taylor called A Stroke of Insight. And she's going to explain the right brain and left brain to you. So I'm not going to steal her thunder for that video. So stay tuned for that. Then she'll also talk about the connection of self and others. So I'll let her, in her wisdom, explain that to you. But what does that homeostasis look like? And how far away from that homeostatic line is too far? What does a disease state look like, right? So Parkinson's versus schizophrenia, how far do we have to stray from a normal dopamine response in order to actually call it a disease? While other professions are concerned with changing the environment to suit the weakened body, chiropractic is concerned with strengthening the body to suit the environment. I find that to be extremely important in today's time. So we have to understand what's going on around us, but we also have to, we think of it like a garden and a gardener. We look at the soil. What do we want to grow in that soil, right? So what is the quality of the soil? What is the quality of the seed that we're planting? But we also have to take into account, is there rain, is there sunshine? That's the environment around us. So we're going to thrive easily in some environments, and then we have to work a little bit harder on the soil and the seeds that we're planting, a little bit higher quality, depending on if it's rough times. So to me, it's a little bit of both. It's not just one or the other. Everybody gets their own opinion, but I think that's an important concept to understand. But what can we do about it as chiropractors is we can create a better soil for the person, okay, for something else, something better to grow. The idea here of diseases of the day, as I call them, are diseases of the day through lens of functional neurology. So what I want you to understand, and what I think is very important in society, things like diabetes, things like high blood pressure, it's not just move more, eat less, de-stress. It's so easy to say, hey, get a handle on your stress, but like, what does that actually look like, and how does that help anyone? It stresses them out even more. So understanding it, acknowledging it, saying, hey, this fight or flight response that you're having, the sympathetic nervous system response, sets you up to have high blood pressure, sets you up to have high blood sugar. That's the innate wisdom of the body to get you up and out of that stressful situation so you will survive. You'll be able to run or fight your way out of that area and then get back to that cave, right, in ancient times, and then hopefully have a meal and get some rest and get up and do it again the next day. Well, nowadays we're not running home or fighting it out, we're driving home, right? And we're not allowing ourselves to de-stress the way that nature intended it. And so we continue to have that high blood pressure, we continue to have that high blood sugar, and we're not actually using it in the way that the body intended as fuel and increased energy in order to fight. So we need to explain that to our patients, that it is a pre-programmed stress response in order for you to survive. But in nowadays time, in 2020, it's not helpful for us. It doesn't help us survive. It actually is a detriment to our health because we're not using it the way that it should be, that it was made to be used. So we have to explain that part to them, and that maybe your diet is spot on, maybe that your exercise is spot on, and your nervous system hasn't gotten the message yet. And so that's our job, is to convey that message and help them with that aspect of the nervous system and give them tools to actually de-stress. I like to do that through functional neurology, through eye movements, through cranial nerve activities, through understanding the pre-programmed stress response. So if I were scared right now, I would do this. I would look around. You wouldn't know what's coming. That'd be kind of scary for you guys if all of a sudden I did that, right? You don't know that I'm alone in my apartment here and I'm totally fine. But if I did that, that's a cranial nerve response. Okay, so cranial nerve 11, spinal accessory nerve, bringing my upper trap up into my ear here in order to protect my neck from whatever threat might be out there. Okay, so that plus SCM, cranial nerve 11, spinal accessory is SCM and upper trap, so that turn, right? And we're going to understand, or we're going to learn about superior colliculus, inferior colliculus. If I see something out of the corner of my eye, I'm going to turn and look and check it out without even really thinking about it. If I hear something out of the ordinary, I'm going to turn and look and protect myself. Both of those things are a protection response to stress. And so what do? Now we have to deal with that shoulder or that misalignment of the cervical spine because those muscles pulled at the transverse processes and some at the spinous processes, depending on what muscles we're talking about here. And then the little pulley system here that keeps my eyes level with the horizon for the rest of the muscles around the neck. We call them the paraspinal musculature, or the para, around or near muscles around the neck in this case here. So keeping the head at a tilted angle to keep the eyes level on the horizon if I am in a scared position. And we'll see what that looks like in that kind of fight or flight position as well. Okay, so what does that manifestation look like to a chiropractor, to the structures of the body? But neurologically, we want to deprogram that. So I would activate my antagonist of upper trap, which would be my lower trap and my serratus anterior, maybe a couple chaturangas if you're used to yoga, not a regular push-up because it really helps to fire off that serratus anterior, and that lower trap a whole lot better. And then I would kind of tuck my chin and I'd turn my head and stretch that SCM. If it was really locked down, I would act as though I was going to turn my head, but resist that range of motion to fire off that SCM in a safe environment without actually moving it. And the body would go, oh, okay, I'm safe, I'm secure, I'm firing these muscles off, I'm not overstretched. And that would be an example of how to kind of dial back from that aspect here. So shoulders down and back, kind of tuck the chin, turn the head, stretch, and resisted range of motion. We also add in things like eye movements, because that first little thing that we do, first we're scared, right? So we're like, whoa, facial nerve, right? So that kind of startle look. And then we do eye movements, like what's going on, right? So you look around. And then the cranial nerves, so 2 is sight, right? 3, 4, and 6 are going to be eye movements. And so what do we do then? So we de-stress the muscles, right? And then we do some eye movements while we are happy, safe, and secure. So after you help them with their structure, adjust them, you'll understand that, hey, now we need to fire off the antagonistic aspects of what was going on here. So lower trap and serratus anterior would be a great one. And I'll show you a chart for that, the upper and lower cross syndrome chart from Janda. And then eye movements, so basic cranial nerve activities in order to put in a program of de-stressing, so de-escalating that stress response. So one of the things you want to keep in mind throughout your entire chiropractic career, really throughout college and your career, is it all is going to boil down to the 3 T's: thoughts, traumas, and toxins. So thoughts, right? So I was scared for a moment, or pretended like I was scared. I wasn't really scared. So pretending that, right? So that would be the thought process, right? Trauma, what if something came at me like a baseball hit me, right? That would be some sort of trauma. And then toxins, like who knows, right? So what if I decided I was going to just eat like pizza afterwards and like hit myself with a bunch of high omega-6 fatty acids, gluten, and dairy afterwards, and then think I'm going to heal appropriately? And it's a little exaggeration there, but not really. For some people, it would be pretty a traumatic, toxic overload, right? But you want to remember that as we're going through this. Thoughts, traumas, toxins, what's going on in the body? How do we deflame the body? How do we deflame the nervous system? And what was the body's goal of this in the first place? What is that innate intelligence trying to do when your patient comes in with that shoulder that's stuck in their ear and they're like, I don't know, can you just work on this shoulder? Is that going to work? No, because it's neurologically programmed to protect you. So we have to understand that aspect as well. This is one of my favorite slides. It's the fight or flight and the rest and digest slide. So fight or flight, the caveman there set up. So one of the things you want to look at here is what's going on here neurologically. So look how his leg is dropped back. So in his fight position here, his left leg is dropped back, his right leg is forward. So look at it from a chiropractic perspective, if you will. What's going to happen to that hip? So that left hip probably going to go a little PI, right? So posterior and inferior. That right hip, maybe some AS, or maybe a little different. It depends on what his body's going to do. And then what do you think is going to happen to that sacrum? It's going to get tilted one way or the other in order to compensate, and he's going to end up with an SAR or an SAL. And so that hip is going to drop, right? And the tailbone or the sacrum is going to tilt one way or the other. And then that lumbar spine is going to tilt to compensate. And then the thoracic spine tilts to compensate. And then maybe C6 kicks off, body right, C2, body left, the atlas probably going off to the right. Occiput is going to get involved. Why? Okay, so all of these things are happening. The shoulder's going to go up, and we're going to go into this kind of flexion protection response with the upper extremity. We're going to learn about the rubrospinal tract, or the connection from the brain to the upper extremity that allows for that to happen as a reflex. But this concept here is so that our eyes stay level with the horizon. So we're in this kind of fight or flight position, and we're creating these subluxations. It's a pre-programmed stress response. That hip is going to drop on one side and then probably tilt up on the other side. And that's our leg length check right there, what we're looking for. And then that's our sacral apex check. And then our assessment all the way up the line and why, what's going on there. So if we start off with adjusting just the upper cervical area, if we're like, oh wow, that C2 is really a body left there, let's take care of that first because you're already face up. In my opinion, in my way of doing things, which there's multiple ways of doing things, everybody's got their own technique, but to me that doesn't make sense. So what's happening here is that's that tonic neck writing reflex. So we're stuck here. What made me get into that position in the first place? So I'm going to do a little bit of cross crawl, a little bit of walking it back through some eye movements and de-stress the patient, and then start from the bottom up and adjust the foundation first, basically. If you were in construction and you needed to remodel a house and the roof was crooked and the foundation was crooked, would you remodel the roof first? No, you would remodel the foundation, and you would even that foundation out and then make sure everything was level that way. So that tonic neck writing reflex, maybe you're slamming away at that C2 body left and you can't get it. It's locked down and you're going to do more damage than harm, and the body's going to see that as trauma. But you go in and you gently adjust the lower segments first. It releases that lockdown in order to compensate for that imbalance, and then like butter, you can just adjust and allow that C2 to go right back to where it wanted to be in the first place. And why? Why do we have things like scoliosis? Why do we have these different areas of the body that, oh, nope, I think I'm straight here? No, your cerebellum is supposed to put you back to straight. So it's a neurological deficit that's saying, hey, yeah, sure, this is straight. Right, so you need to get back in touch with the neurological programs that are supposed to help keep you in line. So structural set and then a neurological set and hold is the way that I like to do things. Again, it's just my preference here. Other people study other things and come to different conclusions. That's why you have multiple teachers teaching you different techniques. The parasympathetics here, this one is a great one, that puppy dog in the bowl. So he ate his food and he just fell asleep right there. So that's a great example of rest and digest. So, so many of us are walking around in that parasympathetic, the sympathetic dominant state, and then trying to get into that parasympathetic state. And again, we want it to be little bits of ups and downs, not these really big, kind of all over the place bipolar aspects to that system. I like this picture for the idea of fight or flight and the different hidden effects here. So if you look up to the right, the brain gets the body ready for action, which in turn, it's going to prevent sleep. It's going to give it the body extra energy through higher blood pressure, higher blood sugar, in order to fight or flight. The liver is going to release more glucose, which is sugar. Digestion is going to slow or stop. Urine production stops or slows down. Oxygen, nutrients, blood flow are going to go to the bigger muscles in order to help you run or fight, and are going to not go to the internal organs. So we think about that with things like IBS or irritable bowel syndrome, or menstrual issues or fertility issues. So the blood flow is not getting to those areas by design, and we have to figure out how to get the body to de-stress, but also then start to nourish those internal organs the way that they need to be in order to function appropriately. Adrenaline is the short-term stress response. So add renal, look at those letters in that, those word parts in that word, add, above or upon, renal, kidney. Same thing for epinephrine. Epi is above or upon, nephr, N-E-P-H-R, is a word root for kidney. So it's the exact same thing. Adrenaline and epinephrine, same stuff. Okay, so adrenaline is the short-term stress response. Cortisol is the long-term stress response. So this is what our chronically stressed out patients are battling. So cortisol, it's going to make the blood sugar higher. We look at things like diabetes. It drives diabetes. It drives high blood pressure. It drives the, it depresses the immune system, which doesn't really make that much sense, but the energy's got to come from somewhere, I guess. So I don't really have my head wrapped around that specifically, why that would be a good plan of attack with that. But we do use cortisol for in medicine in order to shut the immune system down. Say somebody had a kidney transplant and their immune system starts revving up. and they need a quick way to get that immune system down besides their normal immunosuppressant drugs that they're on daily, they'll give them a shot of cortisone. So they'll put them on a Medrol pack or something of the like in order to reduce the immune response. So it never really made sense to me why they would give somebody a steroid when they have an infection like they do with a lot of upper respiratory infections. So I just always, that one just never made sense to me. Anyways, so cortisol, so when your patients come in and they've been in chronic pain, arthritis of the knee, and they're like, yeah, I went to my ortho, he gave me a shot, and I felt better for maybe a week or two, and then it came back with a vengeance, and you're like, hey, what was that shot of? And they're like, I don't know. And you're like, okay. And so I don't know what was just shot up into your body, but that aside, it's probably a cortisone shot. Okay, so it's designed to deflame them, but there's a whole host of other issues that come from that. Okay, so that's another story for another day. Just know that that's part of the long-term stress response and part of the idea of how our blood sugar goes up and the blood pressure goes up and the immune system goes down. This slide is basically the slide that goes along with what I was talking about with that spinal misalignment when that fight or flight position. So think again about the ilium and the sacrum and that misalignment that happens. And then what happens when they get stuck there. If we look at the guy on the right and that pain pattern that's happening. So when our patient does not get adjusted and does not get some neuro rehab to de-stress them and tell the body that, hey, it's safe to move and not be in this stressed out position anymore, then we can start to see that that patient, that their pain could be driven by this fight or flight response. This is that upper cross, lower cross picture that I was talking about, so JANDA. So the website's down at the bottom, so what's it, jandaapproach.com, or you just Google JANDA and the website will come up. There's a lot of really great information there. This really brings it all together. So when you're studying neuro, when you're studying the musculoskeletal class with Dr. Herr last quarter, or you're studying your orthopedic and neurological exams, this is a really great thing to remember and kind of recall. So if you look, it's talking about inhibited and facilitated. So look at that inhibited deep cervical flexors, inhibited lower trap serratus anterior. We talked about that already with this kind of stress position. So if you look above that, facilitated being upper trap and levator scap. That's facilitated. Feel your upper traps right now. That's facilitated. They're probably tight. And then the facilitated SCM and pecs, pectorals, pec minor, pec major. Those are facilitated. Those are tight. Okay, so dig in there at that coracoid process. You've got three muscles there that attach to the coracoid process. So your bicep, and then your pec minor, and then your coracobrachialis. So this guy right here rolls in, okay? And then we need to open that shoulder up. Okay, so those three muscles I would lump into this facilitated as well. So coracobrachialis, pec minor, bicep, and then SCM as well. And then how do you turn that off? So we talked about bringing the shoulders down and back for lower trap, and then serratus anterior to kind of hug in towards the rib cage, and then tuck the chin slightly. Those deep cervical flexors. So see, are we sitting here with our chin jutted out and then our suboccipitals getting super tight, right? So that's a pretty common presentation for our patients. Looking down at that lower cross syndrome, so inhibited glutes and abs. Nobody walks in and says, hey man, my glute max is just really tight and my abs are really tight. So that's usually not the problem, right? So abs of steel, buns of steel. Everybody always says work on your core, work on your abs, work on your glutes. So what's the opposite there, or its antagonistic reaction here? So rectus femoris and iliopsoas. Iliopsoas is your major hip flexor, remember. So in front of the lumbar spine, so T12 and the lumbar spine, so behind the belly, behind the organs, on the front and sides of that lumbar spine and T12. And then it goes into that face of the hip, or that ilium area. So that iliac is part of the muscle. And then we technically call it iliopsoas once it passes through that inguinal ligament, but it's going to attach at that lesser trochanter. It's the major hip flexor. So in that seated position up top, that person has short and tight hip flexors. Most of your patients are going to have short and tight hip flexors. We're probably going to have one side short and tight, one side shorter and tighter than the other. If you look at the other picture there on how that sacral misalignment is going to create an issue, one of those iliopsoas are probably going to be just a little bit shorter and a little bit tighter because of that fight or flight stance. It happens not only when we're standing, but that pre-programmed stress response happens when we're sitting as well. Where are they going to come in and say they have the pain? So look at that facilitated aspect of the thoracolumbar extensor. So in order for them to sit up with that short tight rectus femoris iliopsoas anatomy trained there, in order for them to get into this upright position, those lumbar muscles, the paraspinal musculature of the lumbar spine, quadratus lumborum, the whole area where someone comes in and says, I have back pain here, that lower back pain area, those are going to be facilitated and tight, and those are, when you stretch those out, it's really not going to do us that much of a service. When I used to teach massage, I'd say you got to really check iliopsoas first and release iliopsoas, because look at this guy here. So if that's the only thing that's holding him up and he's fighting off that iliopsoas, if we take away that compensation, and this will happen when we're adjusting people and working on people and helping them stretch if we're not aware of this. It's happened to us all. That's why we talk about it, so you know how to get out of it. So if you only release those thoracolumbar extensors, that iliopsoas is now unchecked and is really going to pull them forward. And that's going to cause even more back issues and misalignment issues, and maybe they can't even roll over on the table, is some of the presentations that we would see. So you really just have to release that iliopsoas first, and then fire off its antagonistic, especially glute max. Okay, so if iliopsoas is our major hip flexor, glute max is going to be our major hip extensor. So remember those agonist, antagonistic relationships. We want to fire off its antagonist in order to relax or eccentrically contract or stretch out that agonistic muscle that's locked down, that hip flexor. Okay, so we activate our abs and our glutes, and we help them move in that way. This is our common patient lifestyle. So she's stuck in hip flexion. She's got her shoulder in her ear, right? And that's that cranial nerve 11 firing off that stress response. She really needs like an earpiece or something. And she's eating sugary donut goodness, right? So not really goodness, it's gluten and sugar. So one of the worst things she could be doing. And then she's drinking coffee. My favorite, my downfall, I know. But caffeine, sugar, and gluten, not what we want our patients living off of. So you could deliver the best adjustment and neurological reset that you could ever do. And if they're going back to this lifestyle, it's like slamming their hand in the door. So no matter how many times you reset that hand, not that you're going to reset that hand, but the analogy, and then they're like, great, thanks, I feel great walking out of here, and they go slam their hand in the door again. Is it the adjustment that didn't work? No, it's what they're going back to that's setting that pattern. So they're only in your office for a short period of time. They're at this desk doing these behaviors for a much longer period of time, and it's really hard to combat that. So patient education here on the neurological components of what's going on here. So we'll look at this and explain this throughout quarter 2 and quarter 3 when we come up upon different terms and explaining what's going on in their normal stressful day and how to walk it back and help them heal. So here we like to talk about creating a new program, write a new script, and then neurologically set and hold. So we have our set and hold and our structural adjustment, and then we need to say, hey, you are now de-stressed. You are safe, you are happy, you are healthy, you are okay, and no need to remain in that stressed out position. So one of the things I like to go through is that pep talk I gave you in the beginning. So we find out what is at the center of their motivation, create a path towards it. Do they want to be healthier to be able to play with their kids? That's a great goal for them, right? A selfless goal, and then the ability to actually go out and play and have fun. So give them an idea of where their heading towards, give them that goal, and then de-stress them, structurally reset them with the chiropractic adjustment, neurologically set and hold, deprogram that stress response in them, and then give them something good to look forward to. Neurologically reinforce these new patterns with the same mechanisms that program them for stress. So that anxiety, that survival. So that's those eye movements again, right? So we want to deprogram that stressed out, scared condition there with a nice peaceful condition with respect to that upper cross, lower cross. So you put them in extension. So you stretch out that iliopsoas, activate glute, activate ab, and then deep cervical flexors, lower trap, serratus anterior, release all of those pre-programmed stress responses, and then add in the eye movements once they are safe, happy, and secure. And then following the finger towards the nose a couple of times, and that should help. And we'll explain why that happens. Okay, so that is your introduction. So let's get to the nitty-gritty of the chapter. So every PowerPoint, we're going to go chapter by chapter in Nolte, so you can read ahead if you like. The idea is that you read ahead, you look at the terms, and then when I say the terms, the first glance, really all you have to do is agree that those are real terms and that I'm not making them up. Okay, some of the terms are really weird. I know you probably went through that with quarter one with the muscles. Some of them are just kind of weird sounding. And so that first stage of the game is just word recognition. Okay, this is a real word. This is how it's spelled. This is what its origin, insertion, action is, and maybe I'll remember it tomorrow. Okay, so that's it. That's all you need to do. So you read it once the first time, and then listen to the chapter, listen to my lectures, come to class when we're able to meet together, and then you're like, oh yeah, okay, the book did say that. That makes sense now. So maybe a couple times in, it'll actually start to make sense. I know I need to read it a couple times, hear it a couple of times, and then it starts to click in different ways. And then you can actually use it in your practice instead of just using it to pass the test and pass your boards. Then once you actually own it, you get to implement it in practice and see the magic that happens when you combine neuro rehab with chiropractic structural rehab. It's really amazing stuff. So chapter 1, page 1, here's the outline. So I suggest you have your book out with you or that screen available to you for if you're watching it online. So these I just cut and paste straight up from the outline from chapter 1. So the nervous system has central and peripheral parts. Principal cellular elements of the nervous system are neurons and glial cells. Neurons come in a variety of sizes and shapes, but all are variations on the same theme. Neuronal cell bodies and axons are largely segregated within the nervous system. Neuronal cell bodies synthesize macromolecules. Dendrites receive synaptic inputs. Axons convey electrical signals over long distances. Organelles, note that E-L-L-E, so that's diminutive. So you'll see that over and over again. Organelle or arteriole or venule or bronchiole. It's diminutive of whatever is in front of it. Okay, so tiny little organs in the cell. Arterioles are tiny little arteries. Venules, tiny little veins. Bronchioles, tiny bronchi. Lung structure, okay? Or structures into the lung. So they're not spelled the same, but it has that same sound, that same feel. So you should be able to kind of pick up on that when you see things like that. Macromolecules are transported in directions along the axons, and then the synapses mediate information between our neurons. This is a cool picture. So I found this picture online of myelin. Okay, so Schwann cells are the principal peripheral nervous system glial cells. So it's got this kind of jelly roll, jelly donut appearance to it. And I thought that was kind of a neat picture of it to be able to see that in that scanning electron microscope picture. So you can see on the bottom where I got that from, and you can kind of play around with some of these pictures if you find these interesting. So we talk about the central nervous system and the peripheral nervous system. So central nervous system, brain and spinal cord. Peripheral nervous system, everything else. So this part here, we'll get into it more later. It's just this is the outline, and I thought I'd throw a picture at you to keep your attention. Peripheral nervous system axons can be myelinated or unmyelinated, or this area of insulation around it. Okay, so central nervous system glial cells include oligodendrocytes. Some central nervous system axons are myelinated by oligodendrocytes, but others are unmyelinated. And then we're going to talk about astrocytes, and they're providing structural or stromal and metabolic support to neurons, ependymal cells lining the ventricles, and microglial cells responding to central nervous system injury. So that's the outline. That's where we're going to go. And now we're going to get into more details about each specific area of that outline. So that's how we're going to go through these lectures. It's going to go chapter by chapter, and we're going to look at the outlines and make sure that we hit the high points of those outlines, and then I'll fill in the rest of it with different details that I find interesting and relevant to chiropractic and to the newer things that we know in neurology today. So that's the basic outline of what we're going to follow. So I'm going to take a little break here. You can always take a break whenever you want, but I'm going to pause it for a moment and I'll see you on the next slide. Okay, so the basics here, starting off in the beginning. So central nervous system is the brain and the spinal cord, and the peripheral nervous system is pretty much everything else. So there's debate about if cranial nerve 1 and 2 should be considered central nervous system. But when you want to answer your test questions correctly, it's brain and spinal cord, our central nervous system, and everything else is peripheral. So how to read these slides? If you look at the bottom of the slide there, you can see Nolte page 2. So this is where that picture comes from. So any of the slides, you're going to see different resources on where I got that information from. So the nervous system divisions here. So we have our nervous system, we have our central nervous system, brain and spinal cord, and then the peripheral nervous system, everything else. And then if you look, that subdivides even further. So then we look at autonomic nervous system. That's that fight or flight, rest and digest that we were looking at. You can also add in freeze and appease as part of the sympathetic nervous system. Parasympathetics, the other part of that divergence there, is calming. Okay, so is what it says, but that's the rest and digest, okay, the puppy dog in that dish. On the other side, so we have our autonomic nervous system, and then if you look over at the somatonervous system, soma just means body, remember. So it communicates with sense organs, voluntary muscles, so what you normally think of when you think of your musculoskeletal system. And then we have sensory and motor. Sensory is afferent, ascending, coming into that central nervous system. Motor, movement, so it's coming from the central nervous system out. So maybe it's a reflex and it's just coming from the cord, but then it's going to be dictating muscle movement. One of the ways that we remember this, and I'll use it a lot, is the mnemonic SAD, sensory, afferent, dorsal. So the dorsal aspect of the spinal cord is going to be sensory and different aspects of the gray matter as well. So if it's dorsal, it's probably sensory, and it's SAD. So sensory, afferent, dorsal, or ascending also works in that as well. Central nervous system. So this theme is what we want to remember when it gets complicated. Central nervous system controls and coordinates every single aspect of the body. Chiropractic works because of this. Okay? So when we are adjusting the spinal areas, we want to remember this, and you'll hear this throughout your education here over and over and over again. A couple of cool pictures here. So these are real pictures, even that cool colored looking picture there, that's some nerve cells. Okay, so tissue underneath that scanning electron microscope. The other two are from the bodies exhibit. If you ever had a chance to see that, that's very interesting. They plasticize the nervous system here. They plasticize all of the bodies and the different systems, and you can see them in a totally different way. So there's no way that we could dissect something like this without that. So pretty interesting. Another cool picture here of plasticized nervous system. So pause at any of these pictures and just take a little bit more time and really check it out. You can see the brain, the spinal cord, and then the nerves out to the around the rib cage look kind of cool, and then that lumbar enlargement coming down and innervating where you could see the glutes would be, and then the adductors, and then that big huge nerve of the leg, that sciatic nerve, and then how it separates out, bifurcates out. And so it's kind of neat looking. The Merrick chart. So this is a central concept to chiropractic. So there's a rhyme and a reason for the nervous system in our body. So you want to look at these different spinal levels. Do you need to memorize these for my class? Absolutely not. Do you need to memorize these to be a chiropractor? No. A lot of times people will have this chart out on their front desk and a little part of a postcard or a card that they can give out to their patients. Circle the area that is subluxated and say, hey, this is what we know about the nervous system, where this comes from. We look at it kind of like a circuit breaker, as you'll see on the next slide. So when you look here, my example is C5, C6, C7 area. So if you remember how to find C6, right? So we take our two fingers here, and then we find the little bump on the back of our head that we're going to assume that that's probably C7. How we check and make sure that that's C7 is you take your pointer finger, put it on the bump where your middle finger naturally falls after putting the forefinger, that first finger, on that bump. Nod your head, and you should feel under your index finger that should be pretty stable. It moves tiny little bit. The middle finger, that should be moving with C6 back and forth. So that's how you know that you're going to be at C6. So look at this area here. So when we look, we need to understand that there are 8 cervical nerves. Okay, so 8 cervical nerves, but there's only 7 cervical vertebrae. So the C8 nerve is going to be in between C7 and T1. So then above C7 is C7 nerve. Above C6 is the C6 nerve. C6 to C5. Okay, so on and so forth. So when you look at that C7 area here, okay, so it's talking about the vertebra. Well, you want to look at in here, okay, this area right here. So you want to look at that C6, C7 area. Now this is a kind of a rudimentary chart here, but I like to point it out in the idea of the thyroid gland. It's innervated by C5, C6, C7 area, depending on who you are and what you're reading, and maybe a little bit of all of those. So what happens in whiplash? So remember how much that vertebra is moving, right? Just from nodding your head. Now imagine whiplash. So really a whole lot of quick movement, violent movement, traumatic movement, and then the body's locking that area down in order to try and protect it. So our job is to try and unlock that safely, whether it be with a high velocity, low amplitude thrust, or with some other technique in order to convey that it is safe to move and that it's not traumatic anymore and we don't have to protect that area. So, so when we look at this area here, that nerve feeding the thyroid, right, is now irritated from that whiplash. One of the things I would tell my patients is that and there's studies on the fact that a lot of times people will have hypothyroid symptoms maybe about a month after whiplash because of the irritation to the nerve, to this area, to the thyroid, comes from this area that's irritated from the whiplash injury. So what we see is hypothyroid symptoms, maybe not necessarily hypothyroid clinically on blood work. Usually the number we think about is that it's about 30% reduction of thyroid function in order for it to even start to show up in the blood work. So the testing is, it's just limited. That's what we have. But what we know is this nerve here, innervating the thyroid, it's irritated from this whiplash injury. So I tell them up front, I say, hey, you might start to exhibit some hypothyroid symptoms being depression, lethargy, fatigue. You might gain weight even though you're not eating that much. And you might, the depression part gets a little scary for them if you don't tell them ahead of time. I've had patients come back to me saying, hey, I'm really glad that you told me that because all of those things are happening and I wouldn't know what was going on with me unless you told me that. And I say, just keep coming back. We'll keep repairing this area here. We'll keep working on it. And for the most part, in the past with my patients, they get better, because this was the injury, so the adjustment helps it because that was a structural issue there. I also support it with nutrition and supplements, but again, that's a different class. So The thing here is you want to look, okay, at the area of the spine and then correlate that to what nerves are being serving what organs to that area and correlate for your patients. Okay? So we look at it kind of like this circuit breaker. So very easily you can see that that's where the fan is, that's where the air conditioning is, and if that circuit is flipped, and it would be red for us here for us to easily detect it, it's pretty much what we do. We go through the spine and we say, okay, what area here is stuck, what area here is flipped, and we want to adjust this area and understand the wiring to this area, just like our circuit breaker analogy here. Okay, so the basics here we want you to know in the introduction, first chapter, here is cranial nerves. There are 12 cranial nerves. To attach to the forebrain, that's cranial nerve 1 and 2, the rest to the brainstem. So we look at something called the rule of 4. So we write out 1 through 12, and we'll memorize these, and we'll talk about them basic in quarter 2, and then we get advanced into quarter 3 on cranial nerves and their nuclei and what's going on with all of that. But 1 through 12, and then we're going to write them out. We're going to have different mnemonics. There's a Harry Potter mnemonic. And then you're going to memorize their structure, right? So their number, their name, their function, if they're sensory, motor, or both. And then in quarter 3, we're going to add in their nuclei and a couple more functions and the idea of tracts and things like that. So what are we looking at here? So mixed nerves, so that means that's sensory and motor. So remember our sensory, afferent, dorsal, motor, efferent, that thing. But so we have a sensory and a motor and a both. Each are numbered with Roman numerals and named from rostral to caudal. So rostral, top, okay, and towards, one of my students would say rostral towards the nostril, and that worked really well. Caudal means tail. Okay, so rostral is up and anterior, okay, up and anterior. Here's a nice picture of it, so hang out with this picture for as long as you need to kind of look. So I'm going to draw with my red marker. This is the front area here. So this would be a picture of this here, but flipped this way. So this is, the spinal cord is down here. Okay, so this would be a view this way, coming at it. So right here, cranial nerve 1, and it even looks like a 1, right? There you go, 1 and 2, and it crosses over. These would go to the eyes. You can see why I majored in science and not art, right? There you go. So crosses over here, optic chiasm or chiasma, whichever way you want to call it is totally fine by me. And then we come down here, cranial nerve 3, cranial nerve 4, we see trigeminal or 5 right here, and then come towards the midline, 6. I don't know where he's labeled here. Oh, he's on the other side, but there he goes. 7, okay, and then 8, ooh, and 9, and 10, 11, and where'd he go? There he is. 12. Okay, so this is the medulla here. Okay, pyramids of the medulla are these 2 lines right here. And then the olives hanging out here. Note 12 is in between those pyramids and the medulla. We don't have to worry about those names yet. Right, let's look at the next page here and help you memorize these. Here's a good one for you. So cranial nerves 1 through 12. So the way I had to do this, none of the mnemonics worked for me. So I just memorized the first letter of each word here. It's not the most efficient way to do it, but that's what I ended up having to do a very long time ago. So there's 3 O's here. So O-O-O, T-T-A, F-V-G, V-A-H. So spinal accessory, you can put S there or A. So olfactory, optic, and ocular motor. So olfactory, sense of smell. Optic, sight. You have 1 nose, 2 eyes. Optic is 2, olfactory is 1. 1 nose, 2 eyes. Right? And then that weird oculomotor is the number 3. Oculo, eye. Motor, movement. These move your eyes. Okay? So does number 4. 3, 4, and 6 are eye muscle movers. Okay, so we've got OOTTA. Okay, so trochlear, trigeminal. There's 2 T's. How are you going to keep that straight? Okay, so what I do here is, if you look, we got our O's, right? 1 nose, 2 eyes, and then ocular motor, here for trochlear, and then the next one's trigeminal. Okay, so trigeminal, and then abducens, abduct. Okay, so when this eye looks this way, that's abducting the eye, abducens, lateral rectus. Facial nerve is next, so muscles of facial expression. Okay. Taste, lacrimation, which is tears, salivation, saliva. Cranial nerve 8, vestibular cochlear, so vestibular, think of balance, cochlear, think of hearing. Glossopharyngeal, gloss, tongue. Pharynx is the throat, so pharyngeal muscles. Carotid body reflexes, think of things like blood pressure. And then, lost my spot there, salivation as well. 10, okay, Vegas 10. So Vegas means wanderer. So Las Vegas, the wanderers. They were wandering around in the desert and created Las Vegas. So Vegas wanders to all of the internal organs. So we think of this with our parasympathetics. Okay, so this is going to go to our heart, our lungs, our digestive tract. Spinal accessory nerve, so upper trap and SCM. So this turn and look, this protection, and then turning and looking, or looking the other way, depending on what we're doing. Hypoglossal, tongue movement. Hypo means below, gloss, tongue. So medical terminology is extremely important as you're studying anatomy and your studies. So make sure you are memorizing word roots as opposed to memorizing whole words or trying to just like memorize things like this. If you get the language down, you should be able to understand whatever word they throw at you, or at least get some sort of ability to match a question and an answer with enough information of medical terminology. I put this slide in here to show you there's a bunch of mnemonics. You might want to Google them. There's some weird ones that show up if you Google them, and they are not fit for class. So there's a couple of them here. The one over to the right here, so sensory, motor, and both. Make sure you memorize that. Those are easy test questions. They're always on the boards. They're always on my test. Is this nerve responsible for sensory information, motor, or both sensory and motor? So it's some say Mary Money, but my brother says big brains matter more. And that next to your 1 through 12. So you'll write 1 through 12, you'll write the structures, you'll write their functions, and then you'll write some say Mary Money, but you'll just write the S and the M. Okay? Some say Mary Money, but my brother says big brains matter more. This one is here to tell you that there is a Harry Potter mnemonic. Okay, so on, they traveled and found Voldemort guarding very ancient Horcruxes. Okay, might work. Basic picture here at birth showing adult pattern structures here. So the cerebral hemisphere, so what are we looking at here? So super basics, right? Starting from the beginning. This is the front, and this is the back. Here's your cord. Okay, so cerebral hemisphere, we're looking at the diencephalon, or all things thalamus, thalamus, hypothalamus, epithalamus, subthalamic area. Brainstem is going to be medulla pons midbrain. We are going to memorize that. You are going to be able to say that in your sleep by the time that I am done with you. It's medulla pons midbrain. And we're going to build off of that and the understanding of that and what cranial nerves are coming from where. So medulla pons midbrain. Brain orientation, so this is vocabulary. So you just got used to using things like dorsal for the back, right? And ventral for the front, or anterior for the front. Inferior, superior, anterior, posterior. These are a little different when it comes to the brain, just a little bit. So I want to point out this here, dorsal, superior. So your dorsal fin would be up here, not back here. So this is the dorsal aspect of your body, right? But dorsal aspect of the brain is here, right? Caudal or tail end is here, okay, posterior, and then ventral, inferior, okay, dorsal and ventral, remember. So imagine you're, a dog, or you're looking at the dog. You don't have to imagine you're a dog. Okay? So you're looking at a dog, and that the head would be here. Okay? So dorsal aspect. Okay, so a four-legged animal, picture that. Ventral and inferior, and rostral and anterior. Remember, rostral towards the nostril. So the thing that we think about here with anterior is the brain as it was growing. So all things here are more primitive. Okay, so the spinal cord, and then cerebellum is pretty primitive here. So that's our primitive sense of balance. And then as we come up and around through here, this front area here is more evolved than the back. Okay, so in higher order animals, they don't have that developed frontal lobe. This front area here is who we are as people. This is what we call executive function, or thinking, and our personality lives here. Okay, so lower order animals don't really have a developed frontal lobe. So the idea here is as it's growing, right, it's going to curl and take up every last little bit of space that it can. Okay, so the same thing happens with our intestines. It's all kind of mashed in there, right? But the rostral area, we think of this with the analogy of the fingertip here. So my fingertip is my fingertip no matter where it is, whether it's here or here. Right now, it's going to be the more anterior aspect. Right now, it's going to be more posterior, but it's still my fingertip. Same thing with rostral. Okay, so as it curls under, my fingertip is the rostral aspect in this analogy here. Okay, there you go. Okay, so rostral, anterior, okay, rostral area, fingertip. And then sagittal, transverse, and coronal, those rules still apply. So sagittal, sag, side to side, S for S, sagittal, sad, or side to side. Mid-sagittal just tells us that it's the middle area here for us. Transverse, okay, just cut through here. And then coronal, corona means crown. Okay, so corona, we're, doing this online because of coronavirus. I didn't even think about that as I was saying it, right? And then we have corona here, crown. Okay, also the frontal plane here. Frontal is way too easy to remember though, so they have to do this crowning if you were to put a crown on your head, coronal plane. Couple of points here. So this is the front, this is the back, and we are looking down. Okay, so this big long line in the center is the longitudinal fissure. Fissure is just a crack. Okay, so we have a sulcus, which are those smaller cracks, those little valleys in between the gyri, or these hills here in the brain. But when you see fissure, it means it's a bigger crack than just a sulcus. Okay, so it's bigger. So it's the right side and the left side of the brain that this is separating here. So we have the frontal lobe, parietal, occipital lobe, temporal lobe. Okay, and deep in there, if you retract away, usually if you pull away from that temporal, that's an easy way to access what we call the insula, or the insular lobe. Okay, so think insulated. So right hemisphere, left hemisphere, you can see the blue of the veins, and covered by arachnoid matter. So we'll talk about that. That's pia arachnoid, and dura is the meninges covering our central nervous system. Here's a nice view for it. So again, frontal, right? That's easy enough. And look at the dotted lines there for the separation to that temporal lobe. We'll learn in the lab that that's the lateral fissure. And then separating frontal from parietal is going to be the central sulcus. That's also one of the things we look at in the lab. Occipital lobe in the back there. And then we can see the cerebellum, or the mini brain. This is a functional MRI, so it looks like a piece of artwork. It is not. It is a functional MRI, or what we call a diffuser tensor image. You can look them up and Google them. They're amazing. They're on something called the Human Connectome, and I have that website available for resources on your Brightspace. It's pretty neat looking. You could see the spinal cord in blue, obviously, and then you can see some of those green fibers going back to the cerebellum, and you can see what they're doing is they're following the pathways here of information and the fluid movement, electrical impulses coming through there. It's really fascinating stuff that's pretty new in the science world, so it's kind of neat to look at. All right, this section is the principal cellular elements of the nervous system are neurons and glial cells. Neurons, functional, parenchymal cells. Glial cells, structural, stromal. Right? So it's just vocabulary, stromal, structural, STR, STROMAL, stromal. Right? And then parenchymal are the functional units. So parenchymal, PARENCHYMAL, parenchymal. So it's just telling us functional or structural, but in fancier terms. Nerve cells, so neurons, there's about 100 billion of them. Glial cells, 10 times 100 billion, so a whole lot more glial cells than neurons. So that info is coming at you from Nolte page 2. These pictures are referenced down here, kind of neat looking real pictures there. Neurons, so memorize this here. So the dendrite, the cell body, the nucleus, the nucleolus, those rough endoplasmic reticulum, so giving us proteins. Axon hillock is that funnel coming down. Okay, so if my hand were this picture here, dendrites, cell body, axon hillock, axon. Okay. Note the impulse direction coming from dendrite to axon. Schwann cells underneath that. So Schwann cell in our peripheral nervous system, these are what's giving us our myelin sheath. So if we see Schwann cell, we know that this is the peripheral nervous system. If we had oligodendrocytes giving us myelin, we know that that's central nervous system. And then the little gaps there used to be called nodes of Ranvier. We can just call myelin sheath gaps now. So the nice thing with neurology is we're getting away from calling things by people's names because it didn't really make much sense. So we just are describing it with regular words now instead of naming it after people. But for those of us that learned it from people's names now, we have two things to memorize. So, and then it goes down to the axon, and the axon little terminals there will then meet up with the dendrites of the next cell or the muscle or wherever it's going. So we see that picture. That's what we memorize to help us kind of visualize what these nerves look like, and then we see what it really looks like, and it's that kind of blob over there. It's kind of neat looking that they're able to see that in those little dendritic spines. It always kind of looks like a root system to me for the trees, and then the little spines that kind of come up from there. Kind of neat looking. So make sure you memorize this. This picture shows up pretty much verbatim, just with things cut out of there, and then you're going to have to identify what those structures are. See? There you go, just like that. So you'll see this picture on your exams. So pause here and take some time and see if you can fill this out. Okay. The axon structure, so one axon per cell arising from our axon hillock. So that wrist area here, so that funnel area coming down, we get one axon from there. In some axons, they can be short or absent. Some are the length of the cell. Some can even be 1 meter long. Long axons called nerve fibers. Occasional branches are what we call axon collaterals, are these offshoots. Okay, so think of an offshoot from a plant, axon collaterals. Branch profusely at the end, and there can be 10,000 terminal branches. Distal endings called axon terminals or terminal boutons, kind of like buttons, but boutons. Functional characteristics, so conducting region of the neuron. So neuron function, glial structure. Glial cells have a function as well, but this is how you'll get those test questions right. Obviously, neurons have structure as well, but this is just how we memorize them. So these are the ones that are generating our nerve impulses. Transmit them along what we call the axon lemma or axolemma, so it's the neuron's cell membrane, to the axon terminal or that end area that's going to meet up with maybe the next dendrite or wherever it's going. It secretes stuff, so the secretory region. So we see neurotransmitters. So the way that the nervous system works is it's electricity, right, and chemicals, right, and wiring basically. Okay, so electricity, chemicals, and wiring. It's a little more complex than that, but it's a nice place to start. Okay, so neurotransmitters are the electricity that when we think of it that way. So these are released into that extracellular space or the synapse. Either excite or inhibit neurons, with which axons are in close contact. So our excitatory stuff you'll learn in function. That's going to be glutamate is our most of the time that's our go-to when we're talking about that, and GABA is going to be our inhibitory. So glutamate excitatory, GABA inhibitory. That's what we're talking about here. carries on many conversations with different neurons at the same time. So it's got stuff going on here, 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 a lot of information kind of coming at you, and that nerve has to coordinate everything. It lacks of rough ER and Golgi apparatus, this neuron does. Relies on cell body to renew proteins and the axon relies on the cell body to renew proteins, efficient transport mechanisms, and it quickly decays if it's cut or damaged. We're going to call that Wallerian degeneration. Transport along the axon. So molecules and organelles, little tiny organs, remember, are moved along axons by motor proteins and cytoskeletal elements. So it goes in both ways, anterograde and retrograde. So if you go to a retro party, you're dressing like in the 80s or the 70s or the 60s, back in time, right? So retrograde goes backwards, so towards the cell body. So anterograde goes the way that you just saw me describe, and that plain picture tell you that impulse goes. Retrograde, okay, so organelles that need to be degraded, signal molecules, viruses and bacterial toxins will cruise backwards. Okay, so like herpes virus lives in the nerve. Okay, so lies dormant in the DRG, or the dorsal root ganglion. But herpes zoster, chickenpox virus, that will then become the shingles representation that lives in your nerves and can cruise retrograde along that axon. Okay, kind of creepy when you think about it. Here's a nice picture of this. Not really a nice picture, it's kind of blurry, but it's all we got. I've looked and looked and looked for more pictures that kind of explain what I was just saying, and there's really not that much out there. So you can check that out if you like to look at pictures and understanding things. This is the one from your Nolte book. So it's talking about kinesins and dynins. So kinesiology and dynamic is what you want to think of, right? So movement. Kinesins travel towards the plus end of the microtubule that they're on, away from the center, while dynins travel towards the minus end of the microtubule, so towards the center of the cell. Okay, so just a little bit of vocab there for you. Dendrites. In our motor neurons, we see hundreds of short, tapering, diffusely branched processes, same organelles as in the body. So it's the receptive input region of the neuron. Dendrites, receptive input region of the neuron, convey incoming messages towards the cell body as graded potential. So you'll learn more about that in your function class. In many brain areas, fine dendrites are specialized and they collect information. We saw those little spiky ends in that picture. Here it is again. It's a cool picture. Again, dendrites, axon, and we're not just talking about one-to-one here. It can be communicating with multiple other nerves and organ issue. Structural classification, so grouped by number of processes. Okay, so we have 3 types to memorize. So multipolar, bipolar, and unipolar. Multi, bi, and uni. So all we do is look at the word parts here. Uni, 1, bi, 2, multi, more than 2, right? So 3 or more. So multipolar, most common. Anytime you see anything that's most common, most abundant, anything like that, make sure you memorize those. Those are what we call high yield test questions. We see that show up on our boards. Multipolar, most common, that's what we think of when we think of the nerves. Bipolar, we're going to see this in the retina and the olfactory mucosa. Olfactory, remember, one nose, okay? So olfactory mucosa, so the mucous membranes here for our nose area. Uni, 1, divides like a T, okay, so just 1. Okay. Distal peripheral processes, okay, so let's look at this picture here for you, okay, and you can see where these are. So multipolar, bipolar, and unipolar. You can look at that and check that out. Pause anywhere you want for more info. Multipolar, most abundant. We could see the Purkinje cells of the cerebellum. So remember, cerebellum is the little mini brain back here. And look at all the dendrites in that Purkinje cell. A lot of information coming in here. That's where we get the majority of our balance from, is that cerebellum. So a lot of info coming into that cerebellum. So structure is going to dictate function. And then the pyramidal cells. So we'll learn about this when we're talking about the cerebral cortex and the pyramidal cells of Betz, B-E-T-Z. But right now we're just looking at the different types of multipolars. Bipolar cells, you can see this in the olfactory and the retinal cell. Note the unipolar is for the dorsal root ganglion. Neurons can also be classified according to their connections. So we looked at structure, now we're looking at connections. So sensory and motor, so sensory afferent dorsal, remember. So sensory neurons, either directly sensitive to various stimuli, touch, pain, temperature, or receive direct connections from non-neuronal receptor cells. Motor neurons, right? Movement, and directly on the muscles, glands, or other neurons in the peripheral nervous system, ganglia. So again, that's we can get pretty complex here, but think of it simply like this. So we see something, that's the sensory input. We're like, I'm thirsty, I need some water. And then the motor output is, I'm going to pick up this glass and then I'm going to drink it. Okay, so the brain is that integration of, oh yeah, that's a good idea. Right? And now how am I going to move and accomplish my task there? So that was the simple slide. This one sometimes gets a little bit more complex. So this is a picture of the cord. So that inside area, that H-shape, butterfly shape, that's actually gray matter. It's just this stain like myelin. And so that purple area is actually the white matter. And then the lighter area is actually the gray matter. So it's just the stain. So most sensory and motor neurons live partly in the peripheral nervous system and partly in the central nervous system. So we could see that blue sensory coming from the sensory receptors. It's making a little bump at the DRG there, so dorsal root ganglion, and then coming into the cord. And you could follow those arrows going up and then going through also through that gray area. We're going to learn all about that gray area in chapter 10. We're going to call it the Rexed lamina, R-E-X-E-D, Rexed lamina. And then we could see that integration and then going up to the motor. So again, just sensory, integration, and motor, just like the other slide. For the most part, the central nervous system is easily divided into gray matter and white matter. So we just saw in the core that the inside area, that butterfly shape, that H shape, that's going to be the gray matter, and then the outer area of the cord is going to be the white matter. So myelin is what makes white matter white. Okay, so gray matter and white matter. So gray matter, largely unmyelinated. White matter, mostly myelinated. So in the brain, it's the opposite. So the cord, gray matter in the middle, brain, gray matter on the outside. Okay, so let's look here. There we go. So gray matter on the outside, white matter more on the inside in this picture here. Okay. This picture here, I pointed out the putamen here. So specific areas of gray matter called nuclei. So remember our picture of the cell. So we want to look at that picture of the cell and see the cell bodies as gray matter, and then the axons as white matter. Okay, so gray matter, where those cell bodies are hanging out. We call them nuclei in the central nervous system. So this example here is the putamen is a nucleus in each central or in each cerebral hemisphere named for its shape and its location. Okay, so we see different areas of these cell bodies clumped together, and then we're going to call that clump a name. Okay, so like the putamen or the basal nucleus. Okay, so cell bodies clumped together in the central nervous system, nucleus. Cell bodies clumped together in the peripheral nervous system is going to be ganglia. So think dorsal root ganglia, peripheral. We're going to change it up, and maybe you learned it as the basal ganglia before, but we're now calling it the basal nucleus because of that rule for the central nervous system versus peripheral nervous system. So gray matter and white matter, we just talked about that. So gray matter, region in the brain and spinal cord that contains aggregations of nerve cell bodies. So that picture that I had you guys look at that we'll test you on. Internal anatomy of the cord here. So again, gray matter surrounded by white matter. Again, that bottom picture is just telling you or showing you that that myelin likes that stain. Okay, so it's a myelin-loving stain. Gray matter. So a couple pictures just to kind of drive the point home. White matter. So we're going to call these a couple of different things here. So this slide is a nice, a lot of information in one spot of high-yield test questions. So central nervous system, so what makes white matter white in the central nervous system? It's the oligodendrocytes. Peripheral nervous system, it's the Schwann cells. Okay, so central nervous system, we're going to see the white matter. We're going to have different names of these tracts or these ribbons or these kind of clumps together, pathways of white matter. So we're going to call them fasciculus, funiculus, lemniscus, brachium, peduncle, column. But we're going to talk a lot about tracts as well. So that's usually in chapter 10. Okay? So a couple of vocabulary words here for us. So commissure connects the two hemispheres of the brain. So like the corpus callosum is a commissure. Association connects the regions within the same hemisphere of the brain. And projection connects one brain region to spinal cord, basically. Peripheral nervous system, we're going to talk about nerves, nerve roots, trunks, rami. Organization of cells and fibers in the nervous system. So ganglia, peripheral nervous system. Nuclei, central nervous system. That's what we call those clumps of nerve cell bodies. Okay, so the hand part, not the arm part. Okay, so the hand part. So cell bodies, not the axon. Cortical areas, layers of, or lamina. So layers, think of like an onion layers of nerve cell bodies on the surface of the cerebrum and cerebellum. Comprise the cerebral cortex and the cerebellar cortex. That outer area is called the cortex, and that's not unique to the nervous system. So we're going to see cortex with the kidney. We're going to see cortex with the adrenal gland. So adrenal cortex gives us cortisol. Adrenal medulla gives us epinephrine or adrenaline. So don't hang on to cortex just being a term for the brain. And here's some examples of the ganglia, so dorsal root ganglia, sympathetic trunk ganglia. So if you look right there, there we go. All right, so the sympathetic trunk ganglia, those little bumps on the outside, I think of that as like a little mini spinal cord. My analogy for that one is the red phone at the White House. So you're not making calls for pizza from the red phone. Red phone is for super important stuff. So sympathetic nervous system is using this kind of red phone, the sympathetic chain or trunk ganglion to spread that sympathetic message. So the fight or flight message, right? Sympathetic nervous system, fight or flight. Here's some nuclei of the central nervous system, those clumps of those cell bodies. So we can see the example being the basal nuclei. Here's the cortex, an example of that. Again, pause anywhere you want to hang out with these pictures. So some subdivisions of white matter, so a collection of axons, so the arm in our picture, right? So cell bodies are up here, and then the axons here, that white matter, it's myelinated. So it's fasciculus, funiculus, lemniscus, peduncle, tract. Okay, so could be single, could be some clumped together, and you can see the picture here. You can see medial lemniscus, that just means ribbon. Okay, let's look at some of these here. Fasciculus, meaning from fascicle. You saw this with muscle fascicles in your last quarter with Dr. Herr. So it's just the same thing. It's just a bundle. Okay. Lemniscus means ribbon. Okay, that's all it means. Medial lemniscus, middle ribbon. There's a lateral lemniscus too. All right, so just the lateral looking ribbon. This is another functional MRI, that diffuser tensor image. These are pretty neat looking to me. Functional MRIs. So a lot of times we associate this medial lemniscus with the dorsal column. So spinal thalamic is also going to go through here as well, but we call it the DCML, or the dorsal column medial lemniscal pathway. So the sensory pathway of the central nervous system that conveys sensations, fine touch, vibration, two-point discrimination, proprioception, which is position sense. Okay? Funiculus just means cord, okay? Cord-like structure. So a bundle of nerves enclosed in a sheath of connective tissue or forming one of the many tracts of white matter in the spinal cord. Another picture here, white matter divided into funiculi. Funiculi. White matter consists mainly of nerve fibers that run longitudinally. Okay, so you can see how this is all set up. These are those dorsal columns that I was just mentioning. So this area back here is dorsal. Okay. This is the gray matter here that I'm outlining in red. Okay. And then this whole area here, okay, this whole area, these are all, that's the dorsal columns. Okay, that's all white matter there. And we're going to separate these out. Eventually you'll know these as fasciculus gracilis
and fasciculus cuneatus. That picture explains everything, doesn't it? There you go. Let me erase some of that. There you go. So you can actually see it. All right. Next slide. Peduncle just means stalk. Okay? Again, don't attach it to just things in the nervous system though. So we talk about, that's a colon over there. So pictures of a colonoscopy. So that's a pedunculated polyp. So there's a stalk on it. Okay? So peduncle just means stalk. So we talk about, I highlighted it here at the superior cerebellar peduncle, inferior cerebellar peduncle, middle cerebellar peduncle. Okay? So peduncle just means stalk, or this kind of area. So stalk bearing a flower or fruit. Okay? Tract, nomenclatures. Okay, so nomenclatures. So these are really they seem really complicated at first, but then once you get it, you're just like, oh, why didn't I get that before? But it's just like anything. We're at the bottom of the learning curve, and then you'll be up here, and it'll be all right. So when we're looking at this, here's an example of a tract. So a spinal cerebellar. So coming from the spine, going to the cerebellum. If you're coming from the spine and going to the cerebellum, that's ascending. It's going up. So we look to see where spine is in the word. Is it in the first part of the word or the second part of the word? If it's spinal cerebellar, it's going up. It's an ascending tract. If it's rubrospinal, you don't even have to know what rubro is yet. But if spine is in the second part of the word, that's a descending tract. That's coming from the red nucleus, rubrospinal. Okay, so telling us where it's coming from and where it's going. Where is the word spine? That's going to give it away. First part of the word, ascending. Second part of the word, descending. Spinal cerebellar, collection of axons with cell bodies in the spinal cord and synapses, endings in the cerebellum. So we'll look at these different tracks. Okay, so they're bilateral. They're on both sides. It's not just a right or a left, but they're not color coded for real in the lab. They just kind of organized it this way so it wasn't too confusing to study it. So again, not necessarily knowing what these tracks do. You can kind of look at this and go spinal thalamic, spine to thalamus. Okay, that's going up. Spinal cerebellar, we just looked at that one going up. Dorsal white columns doesn't really tell us that, so that's fasciculus cuneatus and fasciculus gracilis. We haven't really gotten there yet. Descending tracks, corticospinal, going from the cortex to the spine, that's descending. Rubrospinal, spinal's in the second part of the word, red nucleus to spine. Descending, reticulospinal, vestibulospinal, tectospinal. You get the idea with that. Peripheral nervous system. So we're going to talk specific bundles of nerve fibers. We're going to call them nerves, nerve roots, trunks, cords, rami. We're going to look at the brachial plexus as well, so that'll kind of come in handy with that. And then the different horns of the gray matter, just dorsal, lateral, and ventral. Dorsal, sensory, afferent, dorsal, remember. So sensory is in the dorsal horn, ventral, motor. Lateral, we could see that small and only in those areas. Let's keep moving. There's a nice picture of a real cord here. Rexed lamina, so that's in that gray area that, as I mentioned earlier, we're going to look at the specifics of this in chapter 10. The idea here is just to let you know that there are more specifics coming. Okay, so there's a rhyme and a reason, and we know what all of those little teeny tiny areas do. So that cord really just the size of the tip of your finger, and they're able to figure out what everything's doing in there, kind of. Right? They're finding out more and more. Neuronal organelles are distributed in a pattern that support neuronal function. So again, we're looking at chemistry and electricity, support structures to accomplish this communication and our survival. We have 99% of the cytoplasm in the axon, so it has to have different ways. Okay, so I have switched over to audio only instead of video as well, even though studies show that video helps the listener to stay engaged. But the sheer size of this file because of the video is going to make it impossible to keep this up with my computer and with storage issues. So switching over to no video, just the microphone. This is a really cool slide, so go ahead and play this. The link is down at the bottom. What you're going to see is those two attachments there for electricity. It's hooked up to a car battery,
and what I believe is a railroad tie nail into that wood, and they do artwork like this. And when I saw this, I was fascinated by it because it doesn't go in a straight line. So the electrical current from one to the other, you would think maybe it's just going to go in a straight line. Nope, it goes maybe in the path of least resistance. And what that looks like, it kind of looks like roots, right? But if you look with a nervous system perspective, it looks like a nerve. It looks like electricity, like lightning. So nerves kind of flare out, kind of grow in this way as well. Look back at the Purkinje cells in the cerebellum at that slide, in that picture. That's more of an extreme of all the dendrites. But we see these microcosms and macrocosms over and over again in our world, and microscopically as well. And then I also do acupuncture and electroacupuncture, and so to me this looks like those little alligator clips that you put on the acupuncture needles. So the nail and the needle are pretty easy analogies to see there, and the electricity coursing through it, not a straight line, looks more like a nerve. And the branches of that. So check that out. I think it's a really good thing to keep in mind for a perspective of the nervous system when we're talking about things that we can't really see readily with the naked eye. Even in the lab, you're not really going to see it because, of course, the cadaver is deceased, and so we're not actually seeing it alive, body electric. So this is a nice visual to kind of keep in mind as you're studying neurology. So back to the book here. So neuronal cell bodies synthesize macromolecules is one of the topics of the outline. So the cell body is the cytosynthesis of our enzymes, structural proteins, membrane components, organelles, chemical messengers. Structure reflects its function. That's pretty much anything with anatomy. It's hard to separate anatomy and physiology out. We do it just for time's sake and studies' sake, but one just goes with the other. Missile body is also known as missile substance, so you could see it in the slide there. On the left, you can see a couple of things going on. You can see an astrocyte. You can see the missile bodies in there, the dendrite, oligodendrocyte there. That's for myelin sheath in the central nervous system. And then over to the right, you can see that it's blown up a little bit, that motor neuron, the missile bodies in there, and then the nucleolus of the nucleus there. Neuronal cytoskeleton. So cyto means cell. So this is the cell's skeleton. So we're talking about microtubules, tubulin, neurofilaments. So remember, neuro just means nerve. So these are just nerve filaments, neurofibrils, microfilaments, just small filaments. And a couple of pictures there that are rather fascinating to me. And it really just looks like when you watch things like atoms kind of splitting apart and what they think that would look like, or nuclear physics, or the thought of that primordial ooze and the electricity that's going on. Those pictures kind of remind me of when you watch those documentaries, those programs. And so again, that microcosm and macrocosm of the body. If you look to the right, it kind of looks like one of those mandalas, right? Nope, that is one of the cytoskeletons. So I think it's kind of interesting that it's got this kind of flower picture to it, but that is also a scanning electron microscope picture of our cytoskeleton, neuronal cytoskeletons. You can see the microtubules above kind of looking rather triangular in shape, right? And then that hollow tube, okay? So that's what that is. That's a microtubule, okay? Just from a different viewpoint. Again, here's our typical motor neuron. So remember, so I'm throwing this back up on the slideshow here to remind you that this picture, not actually what it looks like. So we look at what it looks like under a scanning electron microscope, but this is the classic picture that we memorize just because it's easier for us to fathom. And then we make modifications in our mental visualization of it for the different types of. That's a cool picture, I think. Synapses mediate information transfer between the neurons. So the synapses, the spaces. Okay, really basic here. So where it is communicating to the next neuron. Another picture here to give you a visual. Feel free to pause at any of those. Now this is more of a function slide, but I like these. I use these slides when I was an undergrad, and this is from that Marib book, or the Pearson Education is the publisher at the bottom there. And you can read 1, 2, 3, and 4 in blue lettering there. The action potential arrives at the axon terminal, and then how it goes down. Voltage-gated calcium channels open and calcium enters the axon terminal. And then 3, calcium entry causes synaptic vesicles to release neurotransmitters by exocytosis. Remember, those neurotransmitters are the chemicals. Okay, so the chemistry of what's going on here and how that's going to kind of jump across the lines here. So neurotransmitter, number 4, neurotransmitter diffuses across the synaptic cleft and binds to specific receptors on the postsynaptic membrane. So this is what we thought was going on. Later on, I'm going to show you some pictures of, well, I think we already showed it a little bit in there as well, how the synapse actually sends out projections. So it's kind of cool looking, and how neurology is always changing. So you could see this again. Again, this is function, just to kind of help you get a grasp on things and a perspective on what's going on. Okay, so number 5, so we went 1 through 4 already. Now looking at 5, at those specific receptors there. So binding of neurotransmitter opens ion channels, resulting in graded potentials. And then number 6, neurotransmitter effects are terminated by synapses through transport proteins, enzymatic degradation, or diffusion from the synapse. Okay, so again, that's function, not necessarily the structure of this class. So this one's kind of cool. So this is a real picture, scanning electron microscope picture. Kind of looks like Velcro to me. Also looks kind of like how seeds out in the wild get spread, like burrs do. Again, that microcosm, macrocosm. Again, so that axon of the presynaptic neuron, you can see that in kind of a purple color there, and then the synapse, or the space there. Okay. Let's talk more about myelin sheath. So it's composed of myelin, which is a whitish protein lipoid substance. So when you see oid at the end of a word, that just means resembling or like. So it's like a lipid. So lipids are fat. So it's protein and lipids. So as you're studying myelin sheath, I really want you to understand that this component is damaged in your patients that have multiple sclerosis. So the oligodendrocyte, or in the central nervous system, that myelin sheath is damaged, and that's the salient feature of multiple sclerosis. So I want you to kind of have that in the back of your mind as we're going through the structure and the function, and then we'll touch on multiple sclerosis at the end of this little bit here of this subject. So let's talk about this. It's segmented sheath around most long or large diameter axons. So we call them myelinated fibers. So the function of myelin is to protect and electrically insulate the axon. So this is going to make it fast, and it's going to make it efficient and effective. This is the stuff that makes us high performance. It's high performance, high maintenance. Okay? So non-myelinated fibers are going to conduct impulses more slowly. So not as high functioning, but not as high maintenance, kind of nuts and bolts, the gray matter is. Okay, so white matter is white because of myelin. In the peripheral nervous system, it's made by Schwann cells, and they wrap around the axon in what the books call a jelly roll fashion. So one cell forms one segment of myelin sheath. It's concentric layers of Schwann cells. So we see this plasma membrane around the axon, and I have a couple pictures coming up for you. The outer layer of the perinuclear cytoplasm, we used to call that the neurolemma. And we see this peripheral bulge of Schwann cells containing the nucleus and most of the cytoplasm. So there is that concentric circle, okay, around the axon, and it is basically insulating it and making the impulse along the nerve faster because of less resistance. So this explains it really well, I think. So looking here at number 1, the Schwann cell envelops that axon. So remember our cell body and our axon, that yellow part's the axon. Number 2, the Schwann cell then rotates around the axon, wrapping its plasma membranes loosely around in successive layers. Schwann cell cytoplasm is forced from between the membranes, and the tight membrane wrappings surrounding the axon form the myelin sheath. So this is the Schwann cell, remember. So this is in the peripheral nervous system. Multiple sclerosis is in the central nervous system, and it's the oligodendrocytes. So make sure we have that distinction here. And so this is kind of the play-by-play saying the exact same thing. Okay. There's a picture of it for you. There's the myelin sheath wrapped around. You can see the concentric circles. If you look real close, you can see them as lines. So what's going on here? So this is the brain. This is going to be the oligodendrocytes, or the myelination that happens in the brain. So normal myelination, we're not myelinated yet at birth. Okay? So baby's not myelinated in their central nervous system at birth. That's why they're not functioning yet. So they can't talk, they don't have the ability to walk or crawl. So all these things start to develop, and that myelination is part of that high performance that we see as we start to develop. And then when someone has a demyelinating disease or some sort of trauma that's causing that demyelination, we'll see some of those primitive reflexes start to come back, and problems with speaking, problems with balance and movements. So you'll see that sometimes somebody that's having some trouble with walking, that has multiple sclerosis and has pretty bad symptoms, you might see them walking kind of like a toddler. So understanding how it was myelinated in the first place is important when we're treating these patients. Okay, so myelination in the peripheral nervous system again. So remember MS central, and then peripheral is what this slide is talking about. So the plasma membranes in the myelinating cells have less protein. So there's no channels or carriers. They're good electrical insulators. They're interlocking proteins binding adjacent myelin membranes. So we want to make sure our patients are getting good amounts of proteins, whether they're having myelination issues in the periphery or the central nervous system. So understanding what this is made of is important. So we want good protein, we want good fats. We're going to figure out that we're going to want good vitamin D, we're going to want good B vitamins. So some of the things to kind of think about as we're looking at these structures. So myelin sheath gaps between the adjacent Schwann cells, sites where the axon collaterals can emerge. Now this is a super important concept here. So where can the axon collaterals emerge? They can emerge between the myelin sheath gaps. Super important in understanding something like multiple sclerosis, or why we would demyelinate a nerve. And we'll talk about that later. I just want to point that out. Formerly, we used to call these the nodes of Ranvier or Ranvier. So if you took science a while ago, that's what they were called. Now they're just myelin sheath gaps, a whole lot easier to remember. Myelin sheath gaps between adjacent Schwann cells, sites where the axon collaterals can emerge. I put that in there twice, apparently, so super important. Non-myelinated fibers, thin fibers not wrapped in myelin. So we see them surrounded by Schwann cells, but no coiling. So one cell can surround maybe 15 different fibers. One of the terms that I want you to note and memorize and regurgitate on my exam and your board exam is the concept of Wallerian degeneration. Yes, the W is pronounced like a V. Hi, I'm Dr. Kotiw, K-O-T-I-W, same thing. Anyways, Wallerian degeneration. Transection of an axon in the PNS is followed by a characteristic set of events. Over a period of a week or two, the severed axon segment and its myelin are removed in a process called Wallerian degeneration. Schwann cells jettison their myelin, which fragments and gets gobbled up by Schwann cells and macrophages. Schwann cells proliferate and secrete trophic factors, growth factors, which signal the affected neuron to downregulate growth genes. Now that is the wording that your book put together, so I wanted to give that to you verbatim because I thought it was kind of interesting calling it gobbled up and such. What this is, it's such a simple concept though. So what this is
is if you were to cut the root of a tree, so anything that wasn't attached to that tree anymore would die off. You cut a vine, and then that vine dies off, unless it's here in Florida and that plant keeps proliferating, but you know what I mean. So if you cut off a piece of it, that distal end tends to die off. So it's not like a worm where now you have two wiggly pieces. So it's kind of basic concept here that they call Valerian degeneration. And here is the picture of it. Those are not olives, brown olives looking things there. That's the myelin sheath. That's the Schwann cell. So we can see in picture A, we're looking pretty normal there. And then in B, the axon is severed. And then we see the sprouts coming out, and they cannot sprout if the myelin is there. So if we're demyelinating something, we're probably trying to repair it, is the idea that I want you guys to get. So then the next one here in D, the sprouts are degenerating and the axon is regenerating. So it's pruning. We have a concept of neural pruning, and that's one of the ideas of the nervous system behind autism, is we know that autistic brains don't neural prune appropriately. So again, this is in the periphery, but we can kind of zip back and forth and make it clinically relevant to both. And then in E, we can see the target is reinnervated. That muscle cell there is reinnervated, and we can see that that nerve is back to normal. All right, Schwann cells are the glial cells of the peripheral nervous system. Neurons in the peripheral nervous system and their parts, with few exceptions, are enveloped by glial cells, those glue, remember, for metabolic support and electrical insulation. The PNS neurons and processes, unlike those in the central nervous system, are mechanically supported by connective tissue sheaths. Okay, it's connective tissue sheath. Think of this when you think of in physical therapy, we have a term called neural flossing. Maybe Google what that looks like. Neural flossing for sciatic nerve, pointing the toe, tucking the chin, looking up, and then dorsiflexing the foot. Back and forth, you're going to neural floss that nerve in its connective tissue, in its dural sheath. So kind of interesting concept from that. All peripheral nervous system glial cells are variants of one cell type, that Schwann cell. So some are flattened out, and we call them satellite cells. Let's look at this in a little bit more detail, the regeneration of a nerve fiber in a peripheral nerve. So the next couple of slides has this exact slide, but bigger. So we're going to skip right on into that. So regeneration of the nerve fiber in the peripheral nerve. So one. Okay, the axon fragment. So we see some sort of damage here in this picture. So the cut axon ends seal themselves off. Axon transport is interrupted, causing the cut ends to swell, so inflammation here. Without access to the cell body, the axon and its myelin sheath begin to disintegrate distal to the injury. So we call that Valerian degeneration, remember. And that spreads down the axon. 2, Schwann cells and macrophages, those big eaters, clean out the dead axon distal to the injury. Surviving Schwann cells engulf the myelin fragments and secrete chemicals that recruit macrophages. These macrophages help dispose of the debris and release chemicals that stimulate the Schwann cells to divide. Axon filaments grow through a regeneration tube. Schwann cells release growth factors and express cell adhesion molecules that encourage axon growth. Schwann cells line up along the tube of remaining endoneurium, forming a regeneration tube that guides the regenerating axon sprouts across the gap to their original contact. 4. The axon regenerates and a new myelin sheath forms. The Schwann cells protect and support the regenerating axon and ultimately produce a new myelin sheath. So what are those chemicals that are created there, or released there rather than created? So one of the concepts here is that it's VEGF, vasoendothelial growth factor. So VEGF promotes neurogenesis. VEGF has trophic effects or growth effects on neurons and glia in the central nervous system and peripheral nervous system. VEGF supports neuronal migration in the developing central nervous system. VEGF is essential for neuroprotection in adults. This is important to note.
Okay, so VEGF is essential for neural protection in adults. VEGF may be of therapeutic value in the treatment of neural disorders. Of course, right? So this is a NIH.gov. So this is a PubMed paper back in 2010. So this is a naturally occurring substance in our bodies. And let's talk about this a little bit more. So what's going on here is NSAIDs are known to block VEGF. Now, what's an NSAID? It's a non-steroidal anti-inflammatory. So like ibuprofen is an NSAID. Okay, so the treatment with different NSAIDs significantly reduced VEGF expression regardless of cell line and NSAID study. This is extremely important as a chiropractor. So let's say your patient has some sort of nerve damage, some sort of issue with their nerves. This also goes for bones as well. Okay, so it's regardless of cell line. So this is going to also go for bones, blood vessels. Okay, so repair of the body is required. So VEGF is required for repair of the body. So the treatment with different NSAIDs significantly reduced VEGF expression regardless of the cell line and NSAID studied. Super important here. So one of the things that we know is if your patient comes in pain and they're like, oh, I've been taking ibuprofen, my doctor told me to take ibuprofen to help reduce the pain. It really helps, but I'm just not healing as fast as I want to be. Maybe they're not even aware that they're not healing as fast as they want to be. That ibuprofen slows the healing, and this is a paper that proves that, and this is the PubMed paper. Okay, so National Institute of Health. This is the stuff that we want to be able to reference when we're kind of going against some other physicians' guidelines of, hey, just take an ibuprofen for that pain. You have a broken bone, take ibuprofen for the pain. You have nerve problems, take ibuprofen. No, they're not going to heal appropriately. So if you look down at the bottom, it says inhibition of VEGF gene expression in osteoblastic cells by different NSAIDs is where this paper was taken from, and that was 2018. And again, it's regardless of cell line studied. So how are they going to repair their nerves in the way that I just explained in the previous slides if they don't have the chemical that's dictating to repair that nerve? And then they're not going to heal. Okay, so super important to give them these papers and this information. So let's talk about what that means with our patients with multiple sclerosis. So myelin sheath gaps between adjacent Schwann cells are where axon collaterals can emerge. So now let's take that to the central nervous system. So if we know that we have to demyelinate in the periphery in order to repair that nerve, what do you think is going on in the central nervous system? It's a different cell type, but the concept is still the same. It's a wrapping around the cell for better insulation and better conductivity of that electricity. So let's talk about that with this. So we're looking here at a picture, a drawing of a damaged myelin and then the normal nerve. Okay? Multiple sclerosis, you can see the plaques or the scarring on the brain to the left with the arrows there. So those white spots are not supposed to be there. So you could see where that reference is on the bottom for that. So basically the concept here is that it's been scarred up and replaced with astrocytes is what I've read on that. And the oligodendrocyte is what is being removed here. And we'll actually see oligoclonal bands in a lumbar puncture of an MS patient with an active flare. It's a breakdown of that oligodendrocyte. Why is the body doing that? Okay, so we go back to our training as a chiropractor and we understand innate intelligence of the body. The body's not going to do something and destroy itself without a plan. So what we want to look at it as is a remodeling. Okay, so I have this picture up of the lamp on the right here. So this is how I explain it to my patients, is if the lamp wasn't working and we figured out that it was the wire, right? So the wire to the plug of the lamp, maybe something chewed through it, a rodent chews through it in our scenario here, right? And the wiring is the cause of that lamp not working. So we're like, all right, let's replace the wire. So actually we would probably just order it off of Amazon and get a new lamp, but in this scenario, we're not a throwaway society and we're going to repair this lamp. So what would we do? We would take those wire strippers and strip off the plastic sheath around those wires. So we'd strip that off, we would rewire it, and then we would put electrical tape back up and over it. And then we would have, hopefully, a functioning lamp again. Same thing is happening in the nervous system with our patients with multiple sclerosis. Why is the immune system breaking down that oligodendrocyte? So it sees it as something that needs to be replaced and repaired. And then what's the first thing that it's going to happen as treatment if someone with multiple sclerosis goes into the hospital or goes into the medical office? They're going to blast them with a steroidal anti-inflammatory, not just an NSAID, but a SAID, a steroidal anti-inflammatory, and really shut that immune system down, really shut that inflammatory response down. But we just saw that we need that VEGF in order to repair. So it's counterintuitive to me in my studies and in my treatment of patients with MS. If we study the science, why are we giving them a steroidal anti-inflammatory that's going to shut this down? It would be as if you were to walk into the room of a place being remodeled and they've torn up the floor, they've torn down the walls, right? And it's a mess, and you walk in and go, hey, you did a terrible job in here, this looks awful. Get out and never come back. Now you're just stuck with a mess. And you're like, no, that was the demolition that had to happen in order to properly remodel. And then we would bring things in to repair, and then it would be even better. So we want to understand that concept with our patients with multiple sclerosis. So I explain that to them, and then I explain the fact that myelin is made out of protein and lipoid. So we want really good fats. I say things like coconut oil, olive oil, grass-fed butter, avocado oil, things with high omega-3 fatty acids. And then we want good, clean proteins. So we want like grass-fed beef, chickens that were actually out running around in a pasture eating what they're supposed to, nice good oily fishes like salmon, things like that. But make sure that the things that you're eating, we're eating healthy beforehand as well. There's also studies that show iodine as an important component to myelin. So a lot of MS patients will be taking iodine in order to help with that as well. Methylated B vitamins are extremely important, and I like to point out that we know that the nervous system thrives off of B vitamins, so much so that a pregnant woman is going to then take things like folic acid. We really want our methylated folic acids, but a pregnant woman is going to take folic acid in order to try and avoid neural tube defects. So the actual making of the neural tube, the spinal cord in and of itself, requires folic acid. So that B vitamin component to nerves is extremely important. Also vitamin D. So we want to get our vitamin D up to about 65, 75, 85, even 95 is great. Medical normal is 35 to 100. Wellness level, we want to see it closer to about 75 is the ideal. So there, that's kind of went off on that subject there, but I really want you guys to get that point of why we do things a little bit differently in neuro rehab, or why I do things a little bit differently, because we study the science and we study the basic slides and we go, hey, what did that slide say about this? And then let's carry that over into our clinical practice. So